Hello, and welcome to North Shore Private Hospital's virtual GP education program. This GP education session was recorded from a live Zoom session in October 2021. Saving Skin covers non-melanoma skin cancer, the diagnosis, management options, and Mohs surgery. The presenters are Dr. Joe Dusseldorp, plastic and reconstructive surgeon, and Dr. Shivam Kapila, dermatologist. To gain CPD points for the session, use the quick log function on the RACGP website. 2 points per hour to a maximum of 30 points CPD activities can be easily logged by using the quick log function on your My CPD dashboard as per below. Select Log Your CPD. A new screen will appear. Describe the activity, select the date and type of CPD, insert hours and enter Submit. The hours will be converted to points and recorded in your CPD history. There is an option to add a comment or upload documents for your own records. Any problems, please contact me, Wendy Beera, the GP Liaison Officer at North Shore Private Hospital, at gpeducation.nsp@ramsayhealth.com.au. Started. Our first speaker tonight is Dr. Shiv Kapila. He's a dermatologist, and I'll let him introduce himself a little bit further. So Shiv, do you want to try and share your screen? There we go.
Is that working for you?
That's working. That's perfect. So I will mute myself and you can get going, Shiv.
Well, thank you so much for the opportunity to present today. My name's Shivam Kapila. People call me Shiv. I'm a dermatologist based in Sydney. In the rooms that are sort of, I guess my rooms, the rooms that I practice in are in Burwood at Burwood Park Dermatology. It's in a building which is Specialist Medical Suites. Which I'll humbly say, I've got rooms 3 and 4. My father, who's a hand and microsurgeon, has been there for 40 years, and he has room 2. And room 1 is my older sister. It's the nicest room, but she's my older sister, so I have to accept that. And my other sister's cardiologist next door. So the Specialist Medical Suites is very much a family sort of practice, but in the same way, that's how I like to sort of approach my care to the patients as well. That that it's a nice suburban practice without the sort of rush ins and outs. My personal interests is as a Mohs surgeon is obviously skin cancer, of my own personal choice, I actually don't have any sort of particular interest in cosmetics or of any type. So I guess from that point of view, I always spend time with making sure I look after my patients. So I'm not sure if any of you saw last night, but on Four Corners. But that was an interesting watch nonetheless. But my personal choice is actually towards general medicine in terms of general medical dermatology and surgery, and sort of carry those sort of the ethos of the rooms through there. I also work at a few other places. So I'm actually at the moment finishing a clinic at the Melanoma Institute up in Crows Nest. So I'm still in the scrubs here, and that's a chance to sort of be able to get access to things like total body photography and confocal microscopy and optical coherence tomography, which is obviously the future of detection of pigmented lesions and potentially non-melanoma skin cancers in the future. And I'll actually talk a little bit more about that during the talk today. I'm a staff specialist at Royal North Shore Hospital up in St Leonard's. Obviously I work at Hunters Hill Private, where the team very kindly give me a Mohs list there. So I've got 2 lists a month, and also have access through other locations across Sydney as well. And also most recently Chris O'Brien Lifehouse. So I'm pretty much all over Sydney, which is I guess good, because you get to see a good mix of patients throughout. you've got my details there. I'm always happy to pass my mobile on to patients. Obviously, this is recorded, so not to patients, to doctors. Yeah, obviously, I won't put my number over a recorded webinar. But if you have any sort of, if you want to touch base, please email me or ring Medallia in my rooms, and she'll pass on my mobile, because I think it's probably the easiest way. Even just send a WhatsApp, or I need to squeeze somebody in, or anything like that. So so that's a little bit about me. I'm pretty sure you didn't come to see me. I think you're here to learn a bit more about skin surgery and Mohs surgery in particular. Fantastic. So I originally sort of had this talk as sort of methods, myths, and melanoma in terms of Mohs surgery. And look, obviously it's purposely provocative, but we'll get to it in the meantime anyway. Look, I'll humbly say that we as dermatologists don't do a great job in terms of medical student teaching. Prior to like my university experience of dermatology was 2 clinics, and one was cancelled because it was the national conference was on. So I know a lot of people don't know a lot about what Mohs surgery is, and why it's a different approach to traditional excision, and how it can actually help patients. And so I'd like to talk a little bit more about that. When I finished med school, I thought Mohs was an acronym. It's not. It's a person. So Frederick Mohs is a former surgeon who was, during his research time, devising a way of looking at pathology in a slightly different way, and was able from there to determine an approach that would, well, at least in my opinion, help to assist patients with challenging cutaneous skin cancers. So cutaneous cancers. The aims of it is, it's a type of surgery which allows you to have the patient come in the morning and leave knowing that it's gone. There's no need for the patient to come to get a result of a positive margin a week later and have to be rebooked for excision 6 weeks, 8 weeks down the track. But because all those excisions are done on the day. The aim of the surgery is actually looking at the margins, to ensure clearance, but the focus is really on the disease rather than the margins. And I'll explain that to you a little bit more. And finally, of course, we are aiming to keep the holes as small as possible. And I'll explain why and how that's possible as well. So, and more importantly, the benefits from it too. So what is the patient's journey when they're booked into Mohs? So, I mean, with the challenges we've had over the last 18 months, I've adapted pretty well to the telehealth approach. And so a lot of the times I see patients via telehealth only. We're able to help patients from across the state. Unfortunately, there really is only sort of Mohs within Sydney. There's a new group down in Wollongong who are just starting. But beyond that, there really isn't any Mohs outside Sydney at the moment. So a lot of patients will come in from locally or from Greater New South Wales. We can either telehealth or a pre-op assessment. And with the telehealth, we basically discuss the nature of the consultation, and we book them for theatre. So they come in, they get their checks, they do all of that as planned and as expected. And then after that, we use local anaesthetic to numb the area, and we do the prep and drape as normal. We take a sample of the tissue, we stop the bleeding, pop a dressing on, and that's where things stop. We probably a bit different. We don't close up straight away. We then do frozen section pathology, and we look at the slide, or I personally look at the slide. So we're trained in Mohs surgery to actually interpret the histopathology as well. Now, if everything has been cleared from a cancer point of view, we're able to then bring the patient back in and actually perform the closure. If not, we know where exactly in the area that we've cut remains positive, and we're able to, again, bring the patient in, top up the local anaesthetic if necessary, prep and drape, take a sample, stop the bleeding, and pop a dressing on, and then again get the testing done. And then finally, once it's all clear, we can close it. And whether that's either something as simple as something I can do, or we collaboratively with plastic surgeons like Joe to get the best for the patient. And so that's all sort of a simple enough journey. Obviously, with all the checks and so forth, the patient may be in the environment for an hour and a half to 2 hours, but the actual operating component is typically pretty small, because as you can imagine, taking a small cut, stopping bleeding can only sometimes only takes 10 or 15 minutes. And then they're waiting for about half an hour to 40 minutes for a result. And then they're brought back into the room, another half an hour to an hour for reconstruction, depending on the closure. Sorry. So this is what a typical lab looks like. As you can see, there's some cryostats in the middle, which freeze the tissue and then are sliced into very small slices, where they're then stained using an auto stainer, typically in most instances, where typically H&E is applied, although nowadays more and more immunostains are being utilised to better identify tumour and differentiate cell type. And then, of course, we, as the Mohs surgeon, will actually examine the slides ourselves and look at the interpret the findings. So where and why do we use it? I guess the big thing with standard excision, we all know what we do is we mark out what we can see on the skin, and we then mark a margin of confidence around it. And, I always sort of joke that, when you go to conferences, you always got these big bowls of, free pens or lollies or pens, that you can pick up on the way. And pretty much with most surgical dermatology conferences or skin surgery conferences, you can pick up a bowl or handful of margin papers, because there are so many papers out there saying how wide should those margins be? Should there be 3 mils or 5 mils or 10 mils or 9 mils or everything in between? And the biggest thing about that is it all determines on what you can see with your eye, the margin, and then you cut it out and sew it up. The difference, the challenges sort of exist with a case like this, where you can certainly, taking the histopathology, what we have basaloid, BCC cells in a nodular formation in this visible area, and typically you will see the BCC on the cutaneous component here. In the reticular dermis, you can see more of the infiltrative cords, which are not visible in the epidermis and typically would not be incorporated into your initial marked margins. And as you can imagine, if you took your wide distance around this, you may not actually clear the tumour. And that's where sort of Mohs is really beneficial, in that instead of in that we're able to test it straight away and before having to close it. So moving on further from this is literally the slide I show my patient. So we have 2 lesions in a very similar way. What we do with traditional surgeries, we sort of mark an area of confidence around the area. We see what we can see, and then we mark a margin all the way around it. We then cut it out, close it, send it to the pathologist. You come back in a week later, we have the results. During that week, the pathologist cuts it into these slices, and instead of looking at the white areas, they're actually looking at this small area that is the small trephine between or slide that cuts through the tissue. And the predictable thing is that if it's clear on this side and it's clear on this side, and here, then that's fine. It's clear the tumour. But the problem is that there can always be bits between the tumour, and especially around the edges of the excision, because you can see that there are only the smallest, less than 1% of the edges actually being reviewed. So you've left tumour here, and you've also incorrectly described the tumour as clear. And I think that reflects in the recurrence rates. With Mohs surgery, it's a little bit different, in that what we do is we mark a very narrow margin around the tumour, a functional margin around it. And instead of having a look at this sort of slice of bread, we actually decrust the loaf, so we can have a look at all the way around it, such that if there is that tumour that cord of tumour leaving from the central area, that by looking at all of this tissue edge, we identify that's where it is. So we bring the patient in and say, okay, we've got to take a little bit more. So we take another bite and we cut it out there, and we have a look again, and there's still a bit more there. Until finally, of course, for the sake of representation, we've cleared it out. But not only have we cleared it out, but we've also minimised the need for all of this normal tissue to be removed. And when you're operating in challenging areas like eyelids and cosmetically sensitive areas like noses, ears, and faces, if you're able to avoid taking 3 millimeters on this side, or 5 millimeters on this side, and 3 millimeters on that side, and 5 millimeters on that side, and reduce the size of your defect, you then reduce the size of reconstruction, reduce the scarring in the patient, and therefore have an advantage from that point of view. And so this is really sort of where it comes through. So another representation of what we've done here is imagine that this tumor actually goes three-dimensional through the slab of tissue. But the traditional approach is the bread loaf, where you're literally taking that slice of bread, another slice of bread, and looking at it in that way. With Mohs, what we're doing is we're literally slicing downwards and having a look from the outside in. And so that's why some people call it sort of, horizontal sectioning, although as you can see, it's not perfectly horizontal. It's just much more horizontal than the traditional bread loafing. We then take that tissue and we stain it up ourselves and we place it on the slide and we cut the outside component out. So we cut that slice there. And as I said, this is another representation of exactly that same phenomenon, that you've got this large defect, a large excision, you've cut through the slices, but you left tumor there. So, and that's the challenge of the conventional excision. But similarly with Mohs surgery, what we're doing is we're decrusting the loaf here, we're taking the outside off, and we can identify that there is tumour in that particular portion of tissue there. And the question is often like, well, why don't you take larger margins? Look, firstly, you always can. If you're worried, you're concerned, if the nature of the pathology is such that you are worried or concerned, there's no reason you can't take more. But the confidence here comes in the fact that at least you've taken the tumour that has at least in that sort of central area, and therefore effectively cleared it. Now, this is the myths bit, but technically not really myths, they're considerations. A lot of these have been addressed over the 80 years that this process and procedure has been performed. One of the classic sort of considerations is that a lot of people think it's just those few recurrent BCC and perineural invasion. The truth is that you can use Mohs for all non-melanoma skin cancers. I'll talk about melanoma in a moment as well, but as you can see, that's one of the additional ones on the list. For certain tumours, it ends up being the gold, the absolute gold standard, unquestionable gold standard. So things like microcystic adnexal carcinoma, where you can have a very small little scarred area and then have to sort of literally resect centimetres of tissue to clear it. Extramammary Paget's disease, of course, dermatofibroma sarcoma protuberans. It's again the gold standard for that. And I guess that the biggest thing about it is that it really is not just those recurrent things. We have had an update in the recent guidelines, and one of the biggest updates in the guidelines specifically was the phrases that remind us that it's just a guideline. There has been changes in terms of we just do this and this and this, but unfortunately we know there's been a little bit behind the scenes that sort of has lacked to failed to address the usability of the Mohs technique. We do sound like last night saying all of those things, but basically the logic is that if you have a patient who has a non-melanoma skin cancer, we can feel comfortable to clear it. The classic sort of things that people talk about though are those sort of recurrent sites, larger sites in the H zone, the nose, the cheeks, the eyebrows, and of course ears, perineural invasions, and I said those particular ones in particular. And this obviously is where Mohs shines, because those tumours typically have very poor margins, are very difficult to determine what is, where to cut and where not to. But the truth is that it really is amenable to clearance for all non-melanoma skin cancers and melanoma as discussed. And again, these are sort of those sort of classic lines, large tumours, periorbital areas, aggressive subtypes, irradiated skin. All those things are, absolutely Mohs it really does shine in those instances, because you know that you clear the tumour, you identify the spot, you clear the tumour, and any reconstructions can sort of then follow from there. One of the challenges in the guidelines was a discussion. There was an absence of RCTs, but unfortunately there were RCTs. They just weren't necessarily reviewed. And when we look at these, this from a Scandinavian group, there's sort of a large sort of 5-year follow-up where there is a significant, there is a difference in terms of recurrence rates for primary BCCs at the 5-year mark. So we can sort of see that, the concerns that people often have are that, look, is it actually any better in terms of of clearing the tumour. Look, there is evidence at 5 years, but more importantly, at 10 years, the same group were followed through. And we can sort of see, certainly where there is recurrent tumours, there is a significant difference in terms of recurrence rates in 10 years. But even for primary BCCs, there is a significant difference. And I think that's probably the biggest sort of consideration to have. And the reason is, and I'll sort of come to that shortly, is that knowing that you can rely on it as a process to clear the tumour is a really important sort of path. Now, one of the other questions is the quality of frozen sections. And as you can see here, I've shown these slides to pathologists, and they say, look, that's adequate for their assessment of slides. I don't have the zoomed in but images of these, but you can zoom into to 40 times without any concern. So reliability on the section, the reproducibility of those slides is very high, and therefore we can rely on those things. Those are often sort of fears and misconceptions that people have about it. Now, this is probably the biggest sort of consideration, is the non-congruent tumour. The way that Mohs, I guess, convincingly works is that you have a central tumour that then grows out and grows down and in peripheral directions. And so how do you know that if there isn't an inflammatory response that separates one of the cords and you happen to cut through that inflammatory area? Now, certainly one of and that's fair enough. Ultimately, the implication for that is that there'll be tumour left, and if that is the case, then that tumour will recur, and therefore when you have a look at those rates, we feel comfortable that the frequency of the non-congruent tumour is quite low. And more importantly, the clinical implications are such that there becomes a sort of a reliable sort of concept in clearing the tumour. And then, of course, and that's why people argue that taking a margin is important, because when you take a margin, you effectively are cognitively taking that area that could potentially be a skip lesion. Now, firstly, we never look to determine if there is a skip lesion, and secondly, we know that the implication of those skip lesions aren't as significant as we first thought. So that's certainly one of the considerations when you sort of think to yourself, oh, look, that I don't feel comfortable. I'm not sure if this tumour is going to be clear or not. It more likely than not actually is. Now, the other options we do have, and this is obviously a combination of working at Melanoma Institute and other sort of, and just as a dermatologist, is that we do use medical sort of treatments for skin cancers, and we can utilise them to our advantage. So, in pre-immunostimulation, things like 5-fluorouracil or imiquimod, things like Aldara and Effudex, they will stimulate abnormal tissue. And what you can often do is you can actually use them in an incomplete treatment course to identify what is abnormal tissue. And the classic sort of thing when using these agents is patients will use it plus a centimetre for treating a tumour, or they may use a field and they're shocked to see how much abnormal tissue there is. And this is because these agents specifically target abnormal tissue, and they have abnormal tissue in some way, shape or form. So immunostimulation with these pre-op can be used as a marking agent. At the Melanoma Institute, we do have optical coherence tomography, and that allows us to literally effectively sort of create a pseudo histopathological shape to identify tumour, and we can use that as a margin. It's not perfect. I think Joe's going to show a case that we both did recently, which was mapped with OCT, but then when following the Mohs, the defect was larger. But it is effective in at least giving a bit of a sort of a directed approach for it. Certainly mapping biopsies pre-op are very useful as well. So, a series of 2 or 3 mil biopsies around a tumour can sort of see, look, is there a potential for tumour beyond the visible space, plus a area of incongruity or non-congruent area. But I also make the analogy, why do we take excisional biopsies of melanoma? The reason is because we want to have a look at all of the tissue. And the implications for that is that, I always make the analogy, unfortunately a lot of my analogies are food related, but the analogy I have is that with if you order a pizza with the works and you want a slice with pineapple, you take the slice that most looks like it has pineapple. You eat the slice and there's no pineapple. Now, that doesn't mean there's no pineapple in the rest of the pizza. It just means there's no pineapple in that slice. And that's obviously why we do excisional biopsies for pigmented lesions, is because we want the pathologist to have the whole pizza, to have a look at all the area to be able to make a comment on it. And that's obviously one of the challenges with mapping biopsies, is the mapping biopsy will only tell you what is happening in the spot that you took. And finally, Curette is a really effective tool in determining the size of a defect. So effectively pre-curetting of a lesion, whether Mohs or non-Mohs, is really good at identifying the lesions, because, again, atypical cells don't have those same well-developed adhesions or tight junctions between cells. And therefore, a simple curetting with a blunt metal curette, not a disposable steel curette, because the disposable steel curette can basically curette through anything, so it doesn't matter the size. But the blunt spoon orthopedic theatre curettes can be really useful in better identifying the size. So if a large area curettes, then you feel much more confident. Look, you're more likely than not included any sort of additional areas, and therefore unlikely to have those non-congruent areas. But the last thing is, if you're really worried about, look, I think there might be strands of tumour that aren't connected to the primary central tumour, therefore Mohs won't work, you just clear it with Mohs and then take your 3 millimeters. There's nothing stopping you from doing that. If anything, it addresses that constant argument that people have about, the marked margins are, all the guidelines are based on marked margins. So if you take 3 or 4 or 5 mils around what you see, then you're clear. And so effectively you have that option. It's just that by using Mohs, you've identified it, better. Like one of the sort of considerations I always have with, with that idea of those margins is that it assumes that you know how to identify the margins. So if there's a variety in competence in terms of identifying the tumour, then there is obviously a variety in the quality of there's a variety in the implications of that additional marked margin around the tumour. So, so that's sort of, again, another consideration, which I think does get addressed with Mohs surgery, and which is great. As I said, look, combined cases is a really big thing, and that's where sort of me and Joe sort of are able to help the patients and help you and your patients is, having a clearance of bio-Mohs will, again, get the tumour clear. It will keep the hole small. And the other advantage is that I can work in the morning, I can get something all cleared, and I have the confidence that I don't have to worry about how to close it. I can just have to focus on clearing it, knowing that, look, poor Joe has dealt with every motor vehicle accident, every sort of unplanned sort of surgical case, and all these other additional sort of planned surgical experience, that no matter how big the hole is, Joe will be able to fill it. And I hope that Joe and other plastic surgeons are able to sort of feel comfortable that at least now they can do whatever they want to close this. They can make it look as beautiful as they want, because they don't have to worry about putting a skin graft in to keep an eye on, look, I'm not sure if I've cleared this, I'm not sure if there's anything going to come back. So they can reconstruct it to make it look as good as they like without having to compromise on that for the fear of, have I left any in there? Because, as you know, if you if you take a tumour out and then reconstruct it, the challenge of a positive margin in that reconstruction is significant, because you don't, especially deep margins, you don't know where is the deep margin that I'm meant to be cutting out. Where is the epidermal edge that I've now shifted and moved over in different areas. So the fact that with Mohs you're able to keep the hole small compared to frozen section, get it all done in one go, and then have a plastic surgeon closure and have the confidence that that it's going to look fantastic as well. Basically, man, the combined cases that sort of could be described as a gold standard approach. Where I'll humbly say that, look, there's a lot of cases we do during our training. We have observed measures and exams and logbooks, but I'll humbly say that in the same way there's 1,000 things that Joe that I can do that Joe can't. There's there's more than 1,000 things that Joe can do that I can't. So yeah, that's where the real power of combined cases are. There is a paper that was published last year where there seemed to be a 73% increase in such cases, and I think there's real sort of a great value in the collegial approach. Development of skin MDTs have all sort of meant that we get the best outcome. A lot of times people talk about, or plastic surgeons will talk about the cosmetic unit, and just because we are cutting a small hole within a cosmetic unit does not mean the cosmetic unit cannot then be excised and repaired. So I think I've got a question here. So is there no scar left? Effectively, as soon as you put a knife to skin, there will be a scar. But as you can imagine, the size of the defect is such significantly smaller. So if you know the tumor is, say, 3 mils in a circular sort of shape, but with traditional surgery, you'd take 3 mils plus 3 mils left, 3 mils right, 3 mils top, 3 mils bottom. You're now looking at a 9 by 9 size defect, which then has your burrows above and below that again at approximately 3 times that size. And obviously that's not true, but you're then looking at a 27 mil scar for a 3 mil tumor. So it aim is to avoid that. There's a phrase, I'm actually going to butcher it, but something along that God can heal things scarlessly, but we're simply surgeons. But yeah, I'll obviously, again, I'm not a dermatologist or a surgeon, but in the same way, unfortunately, as soon as knife hits skin, there will be a scar, but the aim is to get the nicest scar possible. So I hope that answers that question, Ying, if you're happy with that. So so that's the best thing. You get the best options of clearing as well as plastic. And as I said, I've sort of stressed this point a lot, but I think this really becomes the most important thing is that the tumor is clear and the reconstruction be done with freedom, and that's really sort of a good way of doing things. Oops, sorry, I opened the Zoom. Yes, now this is also potentially something in the future as well. This is ex vivo. So I mentioned optical coherence tomography. That's a form of ultrasound imaging of the skin. There's also ex vivo, which is potentially the future where we're able, instead of actually looking at slides, we can actually use a device which, like an ultrasound, to create images. Here you can see C is the histopathology, and you can see that in B, that is the identification of the tumor within the skin. But that's a watch this space. Now, very, very quickly with melanoma. The big thing is that if you look at the data, there's been argument for using Mohs for melanomas for years and years. They talk about varying levels of sensitivity and specificity. They've looked at really low recurrence rates, and that's really fantastic. But I have some concerns about it personally, and that's why I personally don't do it. And the biggest thing is, look, I know there are some technical variations in the tissue processing, and there have also been diagnostic differences in terms of interpretation. And a lot of the time it comes because, as I said, we observe the peripheral margin of the tissue in the tumor, and often looking at the central component to the periphery is really important in interpreting the histopathology, and especially when it comes to pigmented lesions. That's only one factor. There are immunostains that have helped to identify melanocytes and atypical melanocytes within the tissue, but it's again, it's that is definitely improving things. But I think, again, it's the experience of doing it over a sustained period. In America, it is such a extensive approach, especially for lentigo maligna and for melanoma in situ. And it's, with sort of, you look at the numbers, sort of 40% of all Mohs surgeons are doing MMS for melanoma. Now, I, again, fortunately, sort of being working at the melanoma unit, I feel very comfortable that we can use things like confocal microscopy to identify the pigmented lesions. I often do serial excisions, stage formal serial excisions, daily. So, you excise, you get the imaging done first thing in the morning. I then come in, take the tissue out, stain it, stop the bleeding, dress it appropriately, and then talk with the formal pathologist about having a review formally with paraffin in 24 hours. If it's clear, great. I either close it myself or I get a plastic surgeon to help close it. And if it's not, then I take additional tissue, formally sand it, and so forth. So that's staged paraffin sectioning, which is different from Mohs surgery, which is frozen sectioning rather than paraffin sectioning. There is again a watch this space about it, and I think we've probably all seen or had a patient who's had a lentigo maligna and several cuts taken, with this enlarging lesion. But I guess that's sort of where I again, also an element of what we're trained to do and what experience we do, and if I don't feel comfortable doing it, personally, and the evidence of my, with my seniors and and mentors is similar, I think it's a watch the space. It's always, I always have this adage that it's you're never first in, but you're never last in, and I think that's probably the best approach for Mohs of melanoma in Australia. America is certainly the first in, but it's, I guess, important to see what their long-term studies are. So what's the take-home messages? So the take-home messages really are that, Mohs offers a capacity to do all the surgery in one procedure. You have that patient who's incredibly time poor and is unable to, people who don't want to, have taken a week off for a surgery and for recovery, and they don't want to have to take another week off in 6 weeks or 8 weeks because the first one wasn't cleared properly. Plus, people don't like the morbidity of wounds healing. They don't like the pain. They don't like those sort of processes. So if you don't feel comfortable knowing that there's an option like Mohs surgery where you were able to get the tumour out in a day, no need for a second operation, no need for a second recovery, no need for second time, then that's really, really good. The fact that the disease is cleared, that that you're comfortable that, look, this vague, non-specific edged tumour, this tumour in the middle of the face, even the incomplete excised tumour, that it's going to be cleared is a really sort of a great thing. And lastly, as I said, smaller defects, being able to identify that we're clearing the tumour and not the margins. So just a quick sort of case discussion. Here we have some photos of some patients of ours. So this is a lesion in this area, and as you can sort of see, if we marked a margin of confidence around this, we're going to get very, very close to the medial canthal junction of the ligaments there. In addition to that, you also have to consider, look, do I have to take a flap from above, and what are my reconstructive options? Here, by being able to keep this small, and this is actually 3 stages, so you can sort of see that there is one piece, and then 2 stages, and this here is a second piece. So not only do we not get it in one, we had to go bigger, yet we've still been able to keep it smaller than a primary excision and that be able to close, and that's sort of where the benefit is. But then conversely, you have tumours like this where you go, oh well, that's fairly well demarcated and fairly well defined. Sorry, this is good dinner vision, isn't it? So, but if you take a margin around this, you go, oh, cool, I've got this. But it's also the depth in which you're going, and that's a really sort of a big factor in clearing a tumour in this area. You have again an area like the tip of the nose where you've got this non-specific tumour sort of in this area, and again you're able to get that together close side to side without any concerns of things like doing a flap or a graft or anything like that. So that's really good. On the converse as well, there are a lot of eyelid cases that we do, and again you have a small little tumour just in there, and then to clear that and realise how large and how involved it is, again it's sort of, you can sort of see, something that looks quite sort of simple and predictable, unfortunately ends up being quite a large case. And then and similarly here, again this small non-specific sort of area actually ends up having quite a significant involvement, and you're able to sort of salvage that space and reconstruct in a simple way without multiple excisions and multiple visits, especially with the patients with sort of cognitive issues and so forth. Again, non-specific tumour of this size, because fairly infiltrative, as you can see. But the size of the defect is huge, and then being able to reconstruct it with a flap and get that cleared and sorted in one visit and one recovery period is fantastic. Again, sort of this is an incomplete excised tumour, and you sort of look at that and go, well, geez, there's not really much there, but the histopathology said it was there. the interesting thing about this one is that the histopathology suggested that it was actually the anterior portion that was positive, but as you can see, it was actually all throughout, and it was positive at the, and it was actually larger there, and we're able to reconstruct that without significant issues. That will drop. She was probably a bit surprised by that all, but that definitely drops, so there's no issue there. You can have multiple tumours treated in one go, so there's 2 tumours individually. We're able to get clearance, and you can see how far these tumours spread. You can obviously have reconstruction around the ear, and that can settle down really nicely. Again, you know, BCCs on nose, fairly non-specific, fairly small. You're able to reconstruct them and do repairs in that way. You've got double tumours, and so here you've got, you know, 2 areas, this area here, which is that there, and then similarly this here, and you can sort of see that we're able to identify the 2 tumours. Now, in this instance, the best defect was sort of addressing the cosmetic unit rather than the single unit there, but that was just a patient who's had, you know, an excision there, an excision there. You know, this is a recurrence, and it's just, you know, a real sort of challenging case. So knowing that we can clear it, it's great. Now, finally, there's this case. Now, this case is a case I had in my training, and this is that classic keep you awake at night case. So a lot of the time with Mohs, we don't know how many closures, how many cuts we're going to take. We don't know how many sets of 40 minutes we're going to take. And, you know, so I generally sort of book 5 to 6 cases a day, and utilize that to to sort of, you know, to know that, look, some days I might be done by midday and other times I'll be done by midnight, and this is the 2 o'clock. So we all unfortunately had 2 o'clock, but this is what during my training. So it's my colleagues, like my mentors rather than mine. So so as you can see, what this is actually a recurrent tumour in an area that had previously been excised, previously had a skin graft, previously had radiotherapy. Now, what we've done in the first instance is we've curated this area, and a lot of that's melted away. We can still see the skin graft there. We've had to cut it into lots of samples. It's a large area and has to be reviewed in that way. Unfortunately, all of that's positive, and so we had to take more. We did eventually get to this stage, and this is the most devastating component of it, is that if you looked at this area and you said, oh, look, you know what, let's send this patient to radiotherapy, because this is obviously the area of the tumour that's positive. That area of tumour is this area. You can see the skin graft here, and the involvement of this tumour that had basically been there for 5 years, that the story is what classic sort of story, you know, husband of the receptionist, of the surgeon, of town, excised. Oh, look, it's you know, it's clear, but it's clear with very narrow margins. Oh, it grew back. Oh, let's take a cut. Oh, look, yeah, look, it's positive again. Look, let's just observe it. And look, we observed it, and unfortunately there was perineural invasion. But the big thing is that if you had radiotherapy in this area, you would not have had radiotherapy, you know, a centimetre from the eyebrow to the lesser occipital line. You would not have been so laterally. Now, this patient, ended up having a free flap, obviously not in my hands, and not on my colleague, not my boss's hands either. But yeah, look, you know, that I always look at this as a seminal case of where Moses indicated, you know, this patient was done under local anaesthetic and some Valium and midazolam. You know, you block nerves, you don't feel the pain, and obviously, you know, we have to be sensitive to that. But that's the really big thing. So I mean, I guess the big thing is that Mohs is something that does happen in Sydney. It is available. It is ready. You know, it's accessible. You know, through Hunters Hill Private, I'm able to offer surgery to patients with insurance, and there's, you know, generally very, you know, a small gap that they need to pay. It's accessible through the, you know, in public environments as well. I'm happy to make arrangements for that. So in non-insured patients, again, there's gaps associated with that, unfortunately, the cost of service of the tech and the service and so forth. But really, it's sort of available. Now, I've got some photos that I chucked in here for the sake of who's in this exciting, but I reckon that Joey's going to make them all look pretty rubbish. So, oh yeah, this one. The patient was desperate to keep this mole. Absolutely desperate. Do you mind if I take this mole? The tumor is pretty much wrapping around it. Now we're able to keep it. Was able to reconstruct it. She was stoked that she could keep a mole. But yeah, so that's sort of, again, all those sort of pictures of, you know, here's a hole, here I closed it. So again, cosmetically sensitive areas, being able to sort of clear these areas are sort of the big things. But as I said, look, the big take-home message is yeah, as I said, look, I'm happy and able to offer the service to your patients. I'm a general dermatologist as well, so I'm more than happy to manage any sort of odd-looking rash and any sort of medical issue as well. I think I'm pretty busy with the medical derm and the Mohs surgery, so I don't do sort of cosmetic. I mean, obviously I like aesthetic surgical outcomes, but I don't do any of the sort of the Botox or the fillers or the lasers or anything like that. So really I like to focus on those sort of things. I think I've absolutely gone terribly over time, so I must apologise for that.
Yeah, you're at time, Chiv. I'm going to wrap you up. Thank you very much.
Thank you.
We might leave questions for the end, just in the interest of time. And we did have some multiple choice questions that she was put together, but also in the interest of time, we might skip over those for now. And we will let Joe start his talk. So, hi, Joe. Would you like to share your screen?
Sure. Hi, Wendy. Thanks for having me.
And you can take over and you can introduce yourself.
No worries. Hi, everybody. My name's Dr. Joe Dusseldorp. I'm a plastic surgeon based in Sydney. Thanks for the intro, Shiv. And yeah, it's a pleasure working with a competent Mohs surgeon. And as you said, Shiv, just to by way of segue, it is always reassuring when you can reconstruct a defect and you know that the wound is already clear and you can really just focus on the reconstruction. So I'll spend a little bit of time at the start of this talk just talking about the management of skin cancers in general on the face, and then kind of where sort of specialist referrals indicated. I think that's useful for you guys to think about, kind of when it's okay to do the closures yourself, because lots of you, I'm sure, do treat skin cancers in your practice, and it's entirely appropriate. There's so many skin cancers. If you send them all to Shiv and I, we'd never sleep. And so we just, I'm really interested in treating those ones that are really hard to treat. And so two of these photos I put here are kind of things that people might think there's no real good solution for, but I'll show you that we're able to achieve pretty good outcomes for a lot of these difficult problems. And that's kind of what interests me in my practice. I also do breast reconstruction. The Dieppe flap operation for women after breast cancer is probably the most common operation I perform, but I also treat, my real penchant is children with missing ears, just known as microtia. If any of you ever see those patients, they're pretty rare. It's about 1 in 6,000 births, but they kind of fascinate me in ways in which we can reconstruct those ears. And if you'll indulge me at the end, I'll show you some pictures of how we do that. This is my affiliations, and obviously Ramsay, I'm affiliated with a bunch of the Ramsay hospitals, including North Shore Private, Hunters Hill, where I work with Shiv, and also Castle Craig. I also have clinics at Chris O'Brien Lifehouse, and my public work is through Concord Hospital. So I'm happy to treat public and private patients regardless of their ability to pay. And so this is my disclosures. I have written a textbook on ear reconstruction, and that's the title there for anyone who's really interested in ears, which is probably none of you. And I have some other paid consultancies which aren't particularly relevant to this talk. So I thought I'd start with some simple kind of take-home messages. Hopefully this helps for the CPD points. But basically the punch biopsy is really the single most important and useful tool in the diagnosis of skin cancer, particularly of the face. And I really stand by this statement, in terms of I get sort of occasional shave biopsies and occasional other types of biopsies. And while the information is still useful, if you had to pick one, this would be my go-to every single time. You get a lot more detailed information about the architecture, which you can miss out on a shave. Certainly scrapings are much less useful. I think really a punch, it's a simple, tool. The actual use of the tool, I've got a little slide here. I'll go through that for any of you that aren't super confident with punches, but even a 2 mil punch where you can close with a single stitch or even not close, just put a dressing, is a great useful diagnostic tool. The second take-home message is that skin cancers of the ears, lips, nose, and eyelids. So basically places on the face that you don't really want to have a skin cancer if you're a patient, or probably you don't want coming into your rooms if you're not familiar with dealing with these areas. They do require specialist referral, and the main reason is because they can be prone to recurrence without aggressive treatment. And by trying to sort of skimp on these areas and take sort of thinner margins because there's cartilage underneath, or if you're not sort of confident, I think you can sometimes leave behind very narrow margins or even little bits of tumor, and that generally doesn't help the patient to with the curative intent that they're hoping that will carry out for them. And then the third message is kind of a hopeful one, which is really that by taking a subunit approach to the face and facial reconstruction, you can have scars that basically are almost imperceptible. And that's really by hiding them in places on the face where, let's face it, as we get older, we all have skin creases. And so we can use those skin creases to our advantage is the point. So the background here is, as you all know, the reason we're having this talk is it affects so many patients, is that non-melanoma skin cancer is so common. In fact, it's the most common cancer in Australia, and it's the only reason it's not listed as such, when they talk about breast cancer and colon cancer, is because they typically exclude non-melanoma skin cancer because it's so much more frequent. It would blow all the other cancers out of the water. Obviously, your role is in the early detection and management of the vast majority of these tumors. And so, the uncomplicated small tumors, an elliptical excision with a narrow margin is entirely appropriate over the whole body. And for a BCC, clinically diagnosed BCC or even punch biopsied, a 3 millimeter margin is adequate. SCC, a wider margin is indicated. And this is, when you don't have access to Mohs surgery, it's always interesting to me that how small a margin Shiv's happy to take, because you can microscopically analyze the entire boundary of the lesion. Whereas when you're really doing so, perhaps not with even magnified sort of eyewear, really picking the edge of the lesion could be difficult, and that's why these margins exist. They're really just margins of caution, but you can narrow these margins in cosmetically sensitive areas, which is why the cosmetically sensitive areas are usually sent for specialist referral, either a plastic surgeon or a dermatologist, or sometimes radiation therapist in an elderly patient. So caution should be faced when we're dealing with, as I mentioned, ears, lips, nose, and eyelid, if we had to just focus in on the areas where we're really concerned. And then I think the guidelines for referral are important to be aware of. And so I'll get to that on the next slide. Just with regards to the skin biopsy, this tool, it comes in lots of different sizes. 3 millimeter punch is perfect. And if you need, more diagnostic information, you can just do multiple punches of a large lesion. The more precise the location, the better. So I do always recommend people take a photograph. Inevitably, when I get a referral, there's never a photograph attached to it. And I tend to, and that's because medical records, faxing, it's just, we're not there yet at spreading digital information. And so if a patient's going to have their phone with them in the consultation with you, and they're going to have it with them in the consultation with me. So if you take a photo on their phone, with a little arrow or with the marked around where you took the biopsy from, sometimes if it's 3 weeks, 4 weeks after the biopsy, the lesion might have totally disappeared. All you can see is the tiny little scar, and there might be 3 or 4 other little scars all the way around. The patient might not even be sure which one it was. So particularly in patients where they're elderly or there's some cognitive issue, I would recommend photography if possible. The other things that we get from the punch biopsy, we get to know the histology, exactly BCC versus SCC versus some other more uncommon malignancy, and we get to know the subtype. This is important, not just for non-melanoma skin cancer, but also for melanoma. And the other things that we get to find out about are things like if there's perineural invasion. We want to see that deep dermal tissue, whether the tumors jumped onto a nerve branch and started to go off down that highway. If it's spread into the lymphovascular system as well, which is more rare, but equally as concerning. And for melanoma, we want to know how thick it is. There's been some really good studies that have showed that sorcerizing a lesion or taking a shaved biopsy in melanoma, it means you don't get that prognostic information that you get from knowing its thickness. And that's becoming more and more relevant as we move into the later stages of melanoma classification and guidelines, and as we move on to different types of treatments as far as immunotherapies and so on. So the guidelines that got published from the Cancer Council's guidelines 2008 focused on things so specialist referral, and they mentioned dermatologists as well as plastic surgeons and radiotherapists, is indicated when you're dealing with high-risk locations. And the reason they're high risk is for what I mentioned before, not just because they're hard to deal with, but also because they're prone to recurrence. And that means that they, for whatever reason, you've got embryonic fusion planes around the corners of the alar of the nose, around the junctions of the ear and the conchal bowl. And so if you don't get around these lesions with a decent margin and a margin of safety that you're happy with, you can have recurrence, and these recurrences can go on a long time undetected. So, close observation is fine, but it can be difficult when you're dealing with deep tissues of the nose, the ear, and the lips. So other referral indications, lesions more than 10 millimeters anywhere on the body. So, big chunky lesions, skin cancer, SCCs of the lips, particularly, and the ears. So BCC of the lip or an ear, if it's small, might be okay for management in your rooms. But if it's an SCC, tend to consider referral, because those can spread to regional lymphatics and require a little bit more of a multidisciplinary opinion. BCCs, when they're infiltrating or morphic or multinodular, these subtypes tend to be prone to incomplete margin excisions when done just under, without Mohs or without frozen section or without some other kind of more cautious approach to clearing the margin. And areas where there is a cosmetic concern. I think that's, needless to say, when patients have tumors on the face, there's often a cosmetic concern, but I think it's where the patient really voices that desire to have a cosmetic closure. It's definitely worth at least getting a second opinion from a specialist. With other things that aren't mentioned in those guidelines, but I think are relevant, are when you can feel fixity. So when the lesion is ulcerated and you try and move the skin around it and it doesn't move, particularly on the scalp, but anywhere over a bony prominence or where there's really no ability to move the soft tissues, that's likely invaded more deeply into the deeper tissues and needs a more adequate marginal excision. If it's ulcerated, it's much harder to tell what's in the base of all that scab and crust, and it can sometimes surprise you once you clean it up and inject a local. What you find is bigger than what you expected to find, and it's also harder to know how long it's been there for. And the final one I would say is induration. What that means is that it feels almost like a scar underneath the lesion. That's a bad sign. That's usually a sign that there's something going on in the subcutaneous tissue plane, which you can't see with the naked eye. And so you really won't know until you get in there, and having something like Mohs, frozen sections, or other type of histological analysis on site is extremely useful. So before I move on, maybe now's a good time to run those questions. Wendy, do you think?
I've just also got a question here from, can you do a punch biopsy of a melanoma, is the question.
You can, yeah. So it's indicated, particularly when they're very large, and you can't do, just a marginal excision. Certainly, if they can do an elliptical excision, a 2 millimeter margin is what's recommended around the melanotic lesion, and that is usually sufficient for, as an excisional biopsy. But otherwise, if it's larger than that, or you can't do it with a complete excision and then a 2 millimeter margin, then if you're suspecting melanoma, a punch biopsy is completely appropriate. So this question, just if you guys want to have a crack at it, all of the following are indications for referral to a specialist plastic surgeon, dermatologist, radiation oncologist, except. So the trick here is that most of these things would be reasons for referral. Any thoughts? Do I have to do one here? I can answer my own.
We've got a few answers coming in.
Okay.
Can you see those live there, Joe, or not?
No, I think I've.
Okay. Not sure why that is, but I'll share the results when another couple come in, cool. And then we'll share the results.
Don't worry, this is not being marked.
No, it's not.
It's just sort of giving you the option to think about these things a little more in detail.
We might leave it there, and I'll share those results. So you should be able to see them now, Joe.
Yeah. So the reason why an 8 millimeter BCC on the forearm is appropriate, because most of the time there's enough laxity in the forearm to do an elliptical excision, and it's not above the 10 millimeter cutoff. So A was the right answer. These patients with an organ transplant or there's an incomplete excision, those are both indications for referral. And a BCC on the ear that's 5 millimeters is probably a reason to send on to a specialist. If it was, say, 2 or 3 millimeters, you might be confident to treat yourself. And then the other specialist referral guideline is more than 10 millimeters for that one. Do you want to do the next one? I think there's sort of 3 in this same vein around specialist referral.
There are, so I'll launch that one now.
So all of the following are indications for referral. Except, so same sort of idea, and
is anyone answering that one?
I'll answer it.
Everyone's stumped. I know we've got some answers coming in.
Shoot from the hip. It's no tricks.
Can you see those answers coming in, Joe?
No, but if you share the
Yep, there's another couple coming in. Just bear with me a sec.
No problem.
All right, just in the interest of time, we'll end it there. And there's results for you to look at, Joe.
Okay, so yeah, as far as the correct answer, what does red mean? The most common answer. Yeah, so actually the correct answer is B. So history of Gorlin syndrome, that should be referred to a specialist. SCC on the lip, referred to a specialist. Morphic BCC, again, is an unfavorable subtype, better to refer, and a patient has cosmetic concern should be referred. So a 5 milliliter BCC on the cheek, which is affected in the periauricular region where you've got lots of laxity and skin creases that you can hide a scar in, is more than appropriate for a GP to manage in the rooms.
Okay, all right.
And then the last one, maybe it's a bit trickier than I thought.
Maybe, Joe.
Sorry about that.
That's okay. Here we go.
Hopefully this one everyone should smash. So the most effective diagnostic tool in the characterizing of skin malignancies of the face, shave, dermatoscopy, confocal microscopy, or punch. And hopefully everyone.
I think we got this one.
Got that one. Yeah, very good. All right. And so when we're looking at how we close, elliptical excisions on the face, what's important to think about is these Langer's lines that you guys might have heard of in med school. There are Langer's lines on the whole body that you can see depicted here, and you can easily just Google Langer's lines if you're not sure where the Langer's lines are. But usually it's kind of if you look for wrinkles on older patients. And in younger patients, you can sort of start to look at where are the kind of Langer's lines and where's the most appropriate angle of closure on the body. In the face, however, they tend to be sometimes a bit counterintuitive than what you might think. They tend to obviously close in the same lines as the wrinkles in that area is the short of it. So you get the patient to really crunch up their face and look in the mirror. But if you can imagine a lesion here, the correct sort of angle of closure would be transversely. Down here, it's going to be obliquely. Down here, it's more vertical again. Oblique on the cheek on this side. In the glabellar region, it's vertical. But on the dorsum of the nose, it's actually straight across. So it's interesting that these are different in different parts of the face, but these are more than appropriate for you guys to be doing without referring on for small lesions. With more complex lesions, we start to then look at these junction zones between facial subunits. Using the word cosmetic in this current climate, Shiv, as a dermatologist, was quite brave of you. But these are cosmetic subunits. That for some reason that word has a dirty connotation these days. But yeah, we look at these junctions between cosmetic subunits as being particularly useful places to hide scars. And the most common techniques that we use: wedge excisions around the eyes and lips, full thickness skin grafts for more complex defects or defects where we're not sure about the ability of a flap to achieve the desired result. Composite grafts are possible. Local flaps really are the mainstay. And sometimes we stage the reconstruction, where we're worried about being able to get a good, nice, accurate reconstruction in one go. We will stage and plan to come back and do a second touch-up procedure as part of the overall treatment plan. So I'll show you a lot of these different examples in the coming slides. So no tricks or tests here. There's a few questions, or maybe we'll just do those last two questions so people can relax. Do you want to just quickly run the next question?
Here we go. There we go. There's another question there for everyone.
So this is worth thinking about. The most commonly performed reconstructive procedures of facial skin cleansers include all of the following except. So split thickness skin grafts, local flaps, stage reconstructions using cartilaginous support, full thickness skin grafts, or composite grafts. Again, no trick questions here, but there is one on that list that we don't do very often, and I'll explain why.
Okay, there's a few answers coming in. Just bear with us a sec. There we go. I'll end it there.
Okay.
There we go, Joe.
So the least common is actually split thickness skin grafts. And the reason for that is that split thickness skin grafts tend to contract a lot more. You've probably seen burn scars from people who've had split thickness grafts that might have even been meshed into a sort of a fishnet stocking type of appearance that's to enable that skin to spread out over a wider distance. Lesions on the face tend to be small, so there tends to be enough skin nearby for us to use either as local flaps or as full thickness skin grafts. So this patient is someone that presents with a lesion just abutting the lower eyelid. And what this was designed to show you is that just by taking out a small wedge of that lower eyelid, we were able to keep the lid margin intact, but bring some cheek tissue across from the side of the face and perform a little Z-plasty to enable that to close without any major issue there. When we have, I'm just sort of moving through the subunits. So I'm sort of around the eye to start with. This one was actually a Mohs excision of a lesion that initially was thought to be not involving the eyebrow, but and then we found it actually did involve having to remove a portion of the brow. Now you could think about doing a full thickness skin graft or something here, but the reality is that would always leave a sort of a patched type of appearance, even if you got a perfect contour match. So we actually did a primary closure, which is almost like a wedge of the brow, sacrificing some brow skin, and that led to a very aesthetic closure. This type of Mohs defect is sort of what Shiv was talking about, where had some kind of incompletely excised thing that's been watched over a period of time. It's just grumbled away for years, basically, after having been partially cleared. And so you have missing part of the ear and also part of the cheek subunit. So this is when we break down into there's two separate issues here. And so using the approach known to some of you, I'm sure, as a facelift, we can actually advance almost all of this, hair-bearing skin in a man. This is a part of his sideburn and beard, up to meet the other hair-bearing skin here. So you can see that leads to quite an aesthetic closure in front of the ear. And we took a local flap from behind the ear, post-auricular flap, to line the ear defect portion. So reconstructing in two separate ways for different subunits, leading to an aesthetic result. This patient has multiple skin lesions at the same time. One is a kind of an ulcerated lesion right at the junction of the cheek and eyelid, and then a lower lip SCC that you can see as a result of smoking. When we approach this, we want to try and hide the scar as best we can in aesthetic subunits and without pulling the lower eyelid down. So we want to avoid an ectropion of the lower eyelid. And so there you can see this. This is also a Z-plasty to perform a cheek advancement. This is a McGregor flap, so named after Mr. McGregor. And this is just a wedge excision of the lower lip, which enables us to take out quite a large margin and then close primarily. And you can lose about 50% of the lower lip and still perform a wedge without the lip feeling too tight and affecting the ability to eat and drink. This kind of thing we do see occasionally, where this is actually a young lady who was a smoker who presented with this really awful SCC of a lower lip. And it's really the dry mucosal portion, hasn't really spread onto the cutaneous side yet. And these cases, once you reach something that's of this size, we perform something known as vermilionectomy, where we actually remove the whole dry mucosa of the lower lip and advance the wet mucosa to meet the cutaneous margin. It looks horrific, and you can imagine having to go through this surgery, but you can see even after a week, the margin of where the lesion was excised is very hard to tell. And that's something which heals with an imperceptible scar. This patient had actually a traumatic lesion, but it makes the point that when you have a defect of skin that's left to heal on its own, it can contract markedly over time. And we need to replace in subunits using full thickness grafts. This is a full thickness graft here from the other eyelid. So a blepharoplasty performed off the other eyelid. Even in the young lady, there's enough skin to do that. And then actually the upper skin graft is hair-bearing skin from the scalp, taken from somewhere up here behind the hairline. And you can just see, I don't have a long-term follow-up photo, unfortunately, but she started to grow natural hairs, not just tattooed hairs, which you can do as well in time, but natural hairs where her eyebrow is that laterally there. And this is the principle that we like to replace like tissue with like tissue. Sorry, just going back, these are the dorsal aesthetic, the nasal aesthetic subunits that are actually 9 of them that involve the dorsum, the sidewall, the tip, the alar, soft triangles, and the columella. And each of these has a different type of reconstructive approach depending on where the lesion sits in relation to these subunits. So it really does require a pretty in-depth understanding of where to hide the scars based on these different subunits. But for small lesions, we don't always need to do that. Like this lesion was very close to the alar margin, and we're very cautious in this location to avoid notching. Notching being, that kind of elevated alar rim margin. And so here we've actually been able to use just a composite graft of skin and some of the deeper fat, because this BCC was quite deep and had extended almost close to the mucosal surface of the lesion. So we needed a replacement of that tissue that was about 6 or 7 millimeters thick. So skin itself is usually not quite enough. We need some fat underneath that as well, and can create quite a flat contour here, which can then, the color will change with time. But the skin is never quite the same as the sebaceous skin of the nose, even in the nasolabial fold where the skin is, morphologically quite similar. This, often will still need concealer and so on for managing those subtle differences. This is a more complex lesion. I think Shiv mentioned before, where we were even surprised after confocal microscopy about the extent of it. And so a larger, more comprehensive flap or graft would have been required to try and get a cosmetic result in this patient. I'll just play this video that shows how we do this, because it's quite surprising to some people to see this amount of scarring for something so small. They might seem as small, but just watching this video, you can see how we get the skin to move down and actually sit within the alar here. And that has its blood supply still attached. You can see the blood supply just here. And then we close the cheek and the nasolabial fold by advancing out from laterally inwards. And that is always a lot more laxity here than immediately on table. So it looks pulled initially and that settles down just over time. But yeah, that's an island inversion flap, which was actually described by a Sydney plastic surgeon named by Russell Aldred, who some of you may know from St Vincent's. And it's a great flap. This is for lesions of the nasal dorsum where we kind of have had multiple goes. Shiv showed pictures where we sometimes have had 3 or 4 goes. And I talked to some of my patients about having sort of a 3 strikes and you're out policy. And sometimes we just have to resurface the whole subunit of the nasal dorsum, or and just remove the whole area in an aesthetic way. And so you can see that we can do that by actually hiding the scars down the side of each nose and at the junction between the dorsum and the nasal tip. This full thickness graft, once it's healed, can be very hard to tell that this man has had extensive oncological surgery. This is an area where we can get a large skin graft from, and we can often close that in an aesthetic way in a facelift type incision. So preauricular skin is usually quite pink and does do a reasonable job. It's a little paler than the nose when you look at this telangiectasia of the tip, but does a good job. Another example where this gentleman had a skin graft done with something more like a split thickness graft, and you can see that sort of rolled in cratered appearance, and he had another recurrence, and we opted to use a full thickness graft. I'm sorry I don't have long-term follow-up, but the contour was much better improved with full thickness graft there. This is a bilobed flap that Shiv showed you some examples of, where the lesion, I do remove some of these just under spec with the 3 millimeter margin, and then close them primarily. And you can get quite aesthetic early results. This has still got redness and swelling to go down, but this can heal in a single procedure without needing. This one is the one I'd love to have had Mohs for, to really understand better how much lesion to take. Unfortunately, in the public hospital, we don't have Mohs readily available as I would like, but we do have frozen section. But again, it's not as easy to access. A large sort of multicentric lesion here on the dorsum of the nose, but by replacing this whole subunit, this is someone that I think actually opted, in her case, she had lots of other skin cancers all over. And I wanted to show you, I think I've written full thickness graft here, but from memory that may have been split because it just looks a bit shinier and a bit thinner to me than I'm not 100% sure. But you can see from grafts on the nose can achieve versus flaps. And here I'll show you what a local flap in one stage can achieve. This was a Mohs surgery. You can see that it's actually been excised all the way down to raw cartilage. And skin grafts don't take very well on raw cartilage. So if I'd wanted to put a skin graft here, I would have had to sacrifice the tip support of the nose and remove this cartilage to have a healthy bed that could then nourish a skin graft. And in her case, we actually were able to achieve that by performing a dorsal nasal advancement flap, where the skin from the dorsum of the nose is pulled down and sutured here. And that can lead to scars that are in aesthetic subunit lines and an aesthetic result. When it's more comprehensive, another man who's 3 strikes and you're out needed the whole dorsum of his nose resurfaced. A forehead flap is an option that can achieve very good cosmesis, but it's unfortunately a two-stage procedure. It requires having this tongue of tissue that is bringing a blood vessel from just above the eyebrow down into the flap, and then a secondary defect that can either put a skin graft or enable to close under just granulation tissue. This can heal, these kind of large wounds very, very well. The final focus of this talk is going to be on ears, because that's my thing. So if you'll bear with me for a few more minutes that we've got, I'll go through these quickly. But we have lesions of the ear that can be, you can move on the subcutaneous tissue overlying the cartilage, the perichondrium. So a graft will work quite well in that situation, taken from just behind the ear, so it's all confined to one location. When the cartilage is about to be denuded and the perichondrium removed, you can still achieve cosmetic results by advancing tissue from the back with a blood supply attached. That's known as a post-auricular advancement flap. And then usually I do a second procedure just to make the gap behind the ear deeper at the second surgery. But this is great when you can do this rather than having to take off that whole upper third of the ear, which is harder to reconstruct. However, when that does happen, we can still bring cartilage in and try and replace that. So, lots of our patients are told that they have little bits lopped off and they say, oh, don't worry about it. You're in your 60s, 70s. Just having a little bit removed here and there doesn't matter. But a lot of people feel amputated when bits of their ears are removed. And I would advocate for reconstructing when the techniques are available. And this is an example of where we can do that in a delayed fashion in 2 stages. When it's even more extensive, we need to take cartilage from the ribs. So just taking cartilage from inside the conchal bowl here is not enough. We need a little bit more structural support. And so we can do that. And as you can see, it's initially flat. So we lift the skin from behind and lay the ear down flat while that all heals. And then we lift it forward secondarily, as I'll show you in this sequence of photos. So this is the cartilage graft put into a skin pocket. So we use a suction drain and we suck that skin down around the ear. You can see we can get nice 3-dimensional contours from rib cartilage, which looks a lot like wax or even wood, the way in which we're able to carve it, and a really aesthetic results able to be achieved. In the bowl inside the concha, we often get nervous about this area because of its tendency to spread down into the meatus and lead to a lot more complex treatments needed. I love these are my favorite skin cancers. If you ever want to send these to anyone, please send them to me. I can take a really wide margin here, remove the cartilage from underneath as well because we don't need it, and then bring the skin through from behind in the sulcus in what's called a flip-flop flap type procedure and obtain primary closure in a week. So no need for a graft, no need for a secondary defect. It's usually not very painful, and I can take a wide margin, including the cartilage underneath. So, if you were going to do a graft, you might want to keep the perichondrium on the graft to avoid there being that hollowed out appearance. But by doing it this way, it's a really nice flap closure. We can do these for pretty much anywhere in the conchal bowl, or even in the lower third of the ear, or even up here, just wherever, so long as it's somewhere in proximity to the fold behind the ear, the crease of the post-auricular sulcus, we can do that type of flap. This is another example of a 2-stage approach. This actually was one of my mentor's cases, Dr. Françoise Fuman from France, and she used rib cartilage to come and make this tissue here that's missing. We can't do this with skin only. We need support, and that is costal cartilage in the majority of cases, although there are newer and newer options becoming available, which I'll tell you about. This is a total defect. This actually was a traumatic amputation, and you could see that there was basically a need for lifting that skin up and closing the defect in 2 stages. Initially flat. Show you the sequence of this operation. So we take costal cartilage, carve all these pieces in different shapes and suture them together with wire sutures. This is classic costal cartilage rib graft ear reconstruction. And you can see the final result is quite aesthetic. For partial defects, we can do this as well. Again, this was performed in 2 stages. 1 to implant the cartilage. Actually, the first stage was to remove the keloid scar. 2nd, implant the cartilage. 3rd, make the gap behind the ear. Again, another example of this is what the framework can look like when it's sutured together into multiple pieces. A lot of the cases I'm showing you are traumatic cases, but they equally apply to the cancer situation. It's just that I don't think many people know these types of surgeries are available. And this is what I'm telling you about from microtia, so a congenital defect of the ear. where there's really no structure here at all. And we can actually use the mirror image of the other ear to create a 3D plan and 3D modeled ear that we then implant under the skin and with a vascularized temporoparietal fascial flap covering the defect, and give really nice symmetry and the feeling of wholeness to a child who may have been born with a missing part. This is what that implant looks like. You can see the three-dimensional shape and structure is a mirror image of the other side, which is just a beauty of modern technology. And we can then implant that to obtain a really natural looking ear reconstruction. So take-home messages, prepared it from the start. Punch biopsy, as you know, most useful single diagnostic tool if we have to pick one. Number two, the skin cancers, ears, lips, nose, and eyelids really are the areas which require specialist referral. They're prone to recurrence without aggressive treatment. But the good news is that if we hide these sort of skin lesions in aesthetic subunit boundary zones, we can lead to really minimal scarring. And these are the patients that I showed you about before who are happy with me showing their facial photographs. You can probably remember this was the man who had the wedge and the cheek advancement. This lady was the one that had the vermilionectomy. This gentleman was the one who had the dorsal skin graft. And this girl was the lady that had the really deformed outer lateral eyelid. And these boys, if you can recognize them, have had their ears reconstructed. So thank you very much for your time tonight. I appreciate your attention and I hope you found that useful. Please feel free to reach out. Like Shiv, I'm happy to give out my mobile number, but just contact me through our website or just info@joedusseldorp.com. That's our number. And this is the slide for Wendy, I think, for you guys to perform your evaluation.
It is. So if you could all have a go at that evaluation now and give us some feedback on the night, that would be great. And while we do that, we'll answer some questions. Joe, there's a question here for you. What age ear construction was what age was the child with the ear reconstruction?
The youngest we've done is just turned 4. So anytime, usually before starting school is a good time. And it's something where we talk to the parents. They tend to know their kids the best. But traditional ear reconstruction with rib cartilage was not available until the age of about 10 to 12. So it's nice to be able to offer this to kids in an age group where they're not so socially or self-conscious or aware of their appearance. So yeah, about between 4 to 6 is probably ideal.
Thanks, Joe.